Let me tell you the story of a patient. Let's call her Margaret. At 68, she maintained remarkable mental acuity. She completed crossword puzzles every morning and remembered the birthdays of every relative without looking at a calendar. Her daughter called her the family's walking encyclopedia. However, about 18 months after her doctor introduced a new medication into her daily regimen, Margaret called me in tears. Margaret couldn't remember what she had for breakfast. She began getting confused while walking home from the grocery store, which she had visited weekly for 20 years. In one conversation, she would repeat the same question 3 times. A neurologist suspected early-stage Alzheimer's disease. The family was devastated. But there's something no one told them, and it's exactly what you need to hear right now. Margaret's dementia wasn't Alzheimer's at all. The problem was hiding in her medicine cabinet. When we systematically reviewed her medications and made strategic changes under her doctor's supervision, Margaret began to return to her former self. Within 4 months, she was doing crossword puzzles again. This isn't a miracle story. It's an example of preventable medicine. Today, I'll take a closer look at 9 of the most common medications that can steal your memory without you even realizing it. We'll go from often ignored medications to the most dangerous combinations that most doctors never warn you about. I'm Dr. Franklin, and this video could be one of the most important pieces of content you watch this year. Be sure to listen to the first point, because number 1 isn't a specific drug, but a hidden scheme affecting millions of older adults that almost no one talks about. Before we get to the list, I want to clarify an important point. I'm not advocating for you to stop taking your prescribed medications. Please don't do so without consulting your doctor. My goal is to convey that you have every right to ask questions, understand what you're putting into your body, and protect your brain health. Knowledge is not dangerous, but silence is. 9th place, diphenhydramine. Many of you probably have a bottle of this in your bedside table. It's understandable. It's inexpensive, available over the counter, and the packaging claims it helps with insomnia. It seems like a perfectly harmless pink pill. But here's what it actually does to the brain of people over 60. Diphenhydramine belongs to a class of anticholinergics. These substances block the neurotransmitter acetylcholine, the main signal transmitter in the brain responsible for memory formation, concentration, and alertness. In youth, the brain has ample reserves of acetylcholine. After age 60, its baseline level declines. Blocking it even more by taking the drug at night can have significant consequences. A large study published in the Journal of the American Geriatric Society found that older adults who regularly use diphenhydramine face a significantly increased risk of cognitive impairment. Neuroimaging confirmed a measurable decrease in the volume of brain regions associated with memory. The insidious thing is that this substance is hiding in dozens of products you might not even consider antihistamines. Any products labeled nighttime, sleep relief, or sleep formula likely contain diphenhydramine. What should you do in this situation? If you have allergies, discuss second-generation antihistamines, such as loratadine or cetirizine, with your doctor. They don't cross the blood-brain barrier as effectively. We'll talk about safer sleep alternatives later. 8th place, proton pump inhibitors, or PPIs. Many people are told they need to take heartburn pills every morning, and they do so for years without trying to stop. This is one of the most overprescribed categories of medications in the world. The problem is not only the actual use, but also the duration. Most of these medications are designed for 8 to 12 weeks, not lifelong use. PPIs reduce stomach acid. This seems like a simple solution, but stomach acid serves a critical function. It is necessary for the extraction and absorption of vitamin B12 from food. This vitamin is vital for brain health. Its deficiency is clinically linked to memory impairment, depression, nerve damage, and cognitive decline, which so closely resembles early-stage Alzheimer's disease that even experienced doctors confuse the two. A 2016 study of more than 73,000 adults aged 75 and older found that long-term PPI users had a 44% higher risk of developing dementia compared to non-users. But there's another side to this. Research has shown that PPIs can accelerate the accumulation of amyloid plaques, the toxic deposits characteristic of Alzheimer's disease. This isn't just a vitamin deficiency, but a potential direct path to nervous system degeneration. If you're taking a PPI, discuss with your doctor a gradual transition to other medications, such as 8-2 receptor blockers like famotidine. Dietary changes, frequent meals, avoiding nighttime meals, and elevating the head of your bed can significantly alleviate symptoms naturally. If taking a PPI is medically necessary, regularly check your vitamin D12 and magnesium levels. 7th place, bladder control medications. This topic is particularly concerning due to how little information patients receive. Overactive bladder is a real problem, interfering with sleep and degrading quality of life. When a doctor prescribes oxybutynin, the patient naturally starts taking it. But almost no one explains that oxybutynin is one of the most potent anticholinergics in clinical practice. It affects more than just the bladder. This drug easily crosses the blood-brain barrier, directly interfering with the acetylcholine system, which is responsible for learning and memory. Studies have confirmed that people taking anticholinergics long-term experience a physical decrease in the volume of the hippocampus, the memory processing center of the brain. This isn't just brain fog, but structural tissue changes. In 2019, a study published in the British Medical Journal found that elderly people who had used strong anticholinergics for more than 1 year had a 49% increased risk of being diagnosed with dementia. That's almost 1 in 2 cases. The tragedy is that early symptoms, forgotten appointments, lost items, difficulty finding words, are attributed to normal aging. The medication's effectiveness is never questioned. The good news is that newer medications, such as mirabegron, exist. They work through a different mechanism and carry significantly fewer risks to cognitive function. If you're taking oxybutynin and notice changes in your cognitive function, be sure to discuss it with a urologist or primary care physician. 6th place, benzodiazepines. These drugs have helped millions of people cope with severe anxiety, panic attacks, and sleep disorders. For many, they have been a lifesaver during difficult times, and I admit that. However, it's important to know the scientific facts. Benzodiazepines enhance the effects of GABA, the brain's natural inhibitory signal. They are effective for short-term relief, but problems arise with long-term use. A study in 2022, which followed 8,000 elderly people for 6 years, found that those who took benzodiazepines for more than 3 months had a 51% increased risk of Alzheimer's disease. The greatest risk was posed by long-acting drugs such as diazepam, which accumulate over time in fatty tissue, including brain tissue. Biologically, this is explained by the fact that with constant overstimulation of GABA, the brain reduces its own activity. Neuroplasticity. The brain's ability to create new connections and adapt begins to deteriorate. Memory encoding slows, and emotional regulation is impaired. The brain loses its ability to respond dynamically. The pitfall is that trying to stop taking the medication causes severe withdrawal symptoms. Recurring anxiety and insomnia can be much more severe than the initial symptoms, making the medication seem necessary, even though it's actually exacerbating the problem. Important: never stop taking benzodiazepines abruptly, as this can be dangerous. Work with your doctor to slowly, carefully reduce the dosage over weeks or months. Alternatives include buspirone for anxiety, cognitive behavioral therapy for insomnia, and low-dose melatonin or magnesium glycinate. 5th place, statins. Caution is needed here, as statins truly save lives. Cardiovascular disease remains the leading cause of death among people over 60, and for many, these medications are essential. But your cardiologist may not have mentioned that the brain is nearly 60% fat. Cholesterol, in the context of the brain, is not the enemy, but a structural necessity. It forms the myelin sheath, the insulating layer of nerve fibers that allows signals to transmit quickly and efficiently. Cholesterol is involved in the creation of synapses. Without sufficient amounts, neurons have difficulty communicating. Aggressively lowering total cholesterol with statins risks depriving the brain of the resources to maintain its structure. In 2012, the U.S. Food and Drug Administration updated the labeling of statins, adding warnings about possible memory loss and confusion. This recognition followed a review of thousands of adverse event reports. An analysis from 2023 showed that people over the age of 70 who took high doses of statins for more than 3 years in a row experienced a measurable increase in mild cognitive impairment. Importantly, not all statins affect the brain equally. Lipophilic statins, such as simvastatin and atorvastatin, more easily cross the blood-brain barrier. Hydrophilic statins, such as pravastatin and rosuvastatin, have been shown to have significantly less of an impact on cognitive function in comparative studies. If you're taking statins and experience brain fog, ask your doctor about switching to a hydrophilic version. It's also worth checking your CoQ10 levels, as statins deplete this compound, which is critical for cellular energy in the brain. Fourth place, amitriptyline. This drug is often prescribed for conditions unrelated to psychiatry, nerve pain, chronic migraine prevention, fibromyalgia, and insomnia. It's an older tricyclic antidepressant that has been used for decades for a wide variety of purposes. Sometimes doctors choose it specifically for its sedative effect to help patients sleep. But this is precisely what makes amitriptyline extremely dangerous for the aging brain. It is one of the most potent anticholinergics still in widespread use. Its affinity for muscarinic receptors, where acetylcholine functions, is extremely high, higher than many medications specifically designed to treat bladder conditions or allergies. A 2015 study involving more than 3,400 adults aged 65 and older found that high cumulative doses of anticholinergics, with amitriptyline being a key factor, were associated with a 54% increased risk of dementia. Moreover, the damage wasn't always related to a sharp increase in dose. Even small but stable doses over several years created a significant burden. The most troubling aspect is the subtle nature of the process. Rarely are there any sharp warning signs. More often, a slow decline occurs. Difficulty finding words, trouble sequencing actions, and inability to hold complex thoughts. This is often attributed to normal aging for years before anyone bothers to check the medications. For nerve pain, there are alternatives with a much lower anticholinergic burden, such as duloxetine or gabapentin. Doxepin, in very small doses, can be effective for sleep, and modern selective serotonin reuptake inhibitors are significantly safer for mood modification. Third place, antipsychotics. Pay special attention to this, as such situations occur daily in nursing homes and hospitals, often unaware by families. Antipsychotics were developed to treat serious conditions such as schizophrenia or bipolar disorder with psychosis. These are powerful drugs that alter brain function and have serious side effects. However, today they are often prescribed to older adults off-label, simply for confusion, anxiety, or agitation. Sometimes they are used to sedate patients who are difficult to manage in low-staff settings. Over a decade ago, an official warning was issued about the increased risk of death in elderly patients with dementia when using such drugs, but they continue to be prescribed. Antipsychotics work primarily by suppressing dopamine, a chemical associated with motivation, movement, and executive function. Chronic dopamine suppression in the aging brain results in emotional dullness, slowed thinking, memory impairment, and accelerated neurodegeneration. A 2022 study found that older adults receiving antipsychotics for behavioral symptoms were 71% more likely to experience cognitive decline within a year, even if they had no previous signs of dementia. If your loved one is prescribed quetiapine or risperidone without a confirmed psychosis, be sure to ask about the reasons and plan for discontinuing the medication, as well as non-pharmacological interventions. Second place, paroxetine. This drug deserves much more attention. Paroxetine belongs to a group of selective serotonin reuptake inhibitors, like Prozac or Zoloft. These medications are generally considered modern and safe. But paroxetine is an exception. Unlike other drugs in its class, it has significant anticholinergic activity. This feature distinguishes it sharply from its brothers. While Zoloft or Lexapro have virtually no effect on acetylcholine, paroxetine interferes with its function almost as strongly as older tricyclic antidepressants. A review in 2021 confirmed that elderly patients taking paroxetine experienced a decline in short-term memory and verbal function within the first year of treatment, an effect that did not occur with other similar medications at comparable doses. The American Geriatric Society has included paroxetine on its list of potentially inappropriate medications for older adults precisely because of these cognitive risks. The paradox is that it's often prescribed to older adults for anxiety and depression, the very group for whom it's most dangerous. The solution is simple. If you're over 60 and taking paroxetine, discuss switching to sertraline or escitalopram with your doctor. Most patients tolerate this switch well, provided the dose is tapered gradually. First place, anticholinergic polypharmacy. As I said, it's not just one medication that comes first. That's the most important part. Each drug on the list alone might cause only mild forgetfulness or fog, easily attributed to age. But in reality, older adults rarely take just one medication. The average American over 65 takes 4 or more prescription medications daily. Many take 6, 8, or even 10 different medications, including over-the-counter supplements. Often, they're prescribed by different doctors who don't see the full picture. When several of these medications have anticholinergic properties, their effects don't just add up, they multiply. An analysis from 2022, which included more than 280,000 older adults, showed that those with the highest anticholinergic load had a 120% increased risk of developing dementia over 10 years. That's a more than doubling of risk due to pills whose side effects were often not warned about. Imagine a 70-year-old woman. Let's call her Dorothy. She takes a diphenhydramine-based sleep aid, oxybutynin for her bladder, amitriptyline for leg pain, and a morning-after pill for heartburn. 3 of these 4 medications are anticholinergics. Each doctor individually considers their prescription justified, but together they create a burden directly linked to the risk of dementia. And no one, not even the doctor or pharmacist, has put these factors together. This isn't a hypothetical situation. It's the reality of many people. The medical term for this is polypharmacy, and it's perhaps the most under-recognized factor in the development of dementia symptoms today. It's important to understand. Medication-induced cognitive decline is often reversible. I've seen this in practice. When medication load is identified and systematically reduced under specialist supervision, many patients demonstrate a remarkable recovery in mental clarity. Memory returns, personality reemerges, and the fog dissipates. The brain is not a passive organ. It is capable of healing if given the right conditions. Here's your 5-step action plan. Step 1. Write down absolutely everything you're taking. Prescription medications, over-the-counter medications, supplements, vitamins, painkillers. Don't forget even the occasional pills. Step 2. Check each medication against the anticholinergic cognitive load scale. This is an accessible tool that rates medications based on risk. Step 3. Schedule a visit with your primary care physician specifically to review your medication list. Use the phrase, "I want to review my prescriptions to assess my anticholinergic load." A good doctor will appreciate such a responsible approach. Step 4. Ask about deprescription. This is the controlled process of withdrawing medications that are no longer needed or carry unnecessary risks. It's a recognized field in geriatrics. Step 5. If your doctor ignores your concerns, seek a second opinion. You're not being difficult. You care about your health. A geriatric pharmacist can also help with this. Your brain deserves protection. Now you have the tools to begin this journey. Stay alert and informed. Until then.